Good afternoon. My name is Robert Schoevers. It's unpronounceable, but it's written up there. I'm a psychiatrist from the UMCG, University Medical Center Groningen. And I've been involved with psychedelic research, ketamine, classic psychedelics for some time. And now I have the privilege, together with a wonderful team, of setting up the EU SciPol study, which is focused on psychedelics so psilocybin and palliative care. So many of the discussions that we will have here are very exactly on the right moment, because there's quite a number of issues that you come across that have different sides, and the more disciplines you have in the team, the more sides there are and the more complicated it gets. But that's also the beauty of it. And I'm very happy to introduce this wonderful panel to you. Each panelist will introduce themselves and then give you a bit of an idea of their experience in relation to the subject. And then we have a number of issues that we would like to discuss. And we will also leave room for you to ask questions, give comments during the session. And I have to say that Hanneke Muthert, unfortunately, wasn't able to be here today. And she has a very good replacement by Pier, who is from Stockholm University and who will be the last to introduce himself, because I start with Houman. Houman Farzin is physician and family physician, so palliative care doctor and family physician from McGill University in Canada, and he has been involved with compassionate use programs. We had a wonderful lecture, and I will not say more because you're going to say that.
Great, yeah, thanks. Nice to be with you. So I'm a palliative care physician based in Montreal. I work at a major hospital institution, but I also have a community practice. A lot of my work related to this topic has been the use of psilocybin-assisted therapy for patients with advanced cancer. A lot of the treatments were done in a home care delivery setting, and more recently done in a cancer wellness center associated with the hospital. Now slowly exploring bringing the protocols in the hospital, and also the use of ketamine for this patient population. And yeah, I think that's a good intro.
Thank you. Debor Gonzalez is becoming somewhat of a celebrity. You were filmed. I think the whole session is even filmed. You're a researcher from Barcelona, and you work at San Juan Hospital. And you can introduce how you're related to the subject. That's a great project.
Yes. Well, I have been researching on bereavement, on the potential of psychedelics in bereavement during the last 10 years, and I think that I'm going to continue doing that, because I cannot look to another way seeing these improvements, no, and this beauty in the processes. So now I'm affiliated with the San Juan Hospital Foundation, where we are going to try to bring this work on death and dying and grief, no, from a more holistic perspective. And I'm professor in the University also of Clinical Psychology. Thank you.
Thank you very much. Maarten Somers, psychiatrist from UMC Utrecht.
Yeah, can I go ahead? So I'm Maarten Somers. I'm a psychiatrist at the University Medical Center in Utrecht. My main clinical experience with psychedelics is on psilocybin in treatment-resistant depression in the COMPASS phase 2 trial. I'm also involved as a coordinator of the platform on psychedelics in psychiatry of our Dutch Society for Psychiatry, and involved in setting up research for basically what we're going to talk about, psychedelics in end-of-life anxiety, together with Robert, but for oncological patients, in addition to the research for a non-oncology patient that we have already set up.
Thank you. And last but not least, Pier.
Thank you. So I'm a professor of psychology at Stockholm University, and have not done work on elders or palliative care. But I've done quite a bit of work on attachment theory, so that's really where my primary area of expertise is. And I've done quite a bit of research on attachment and religious and spiritual experiences. And I am very happy to be a peripheral part, but still a part of the PsyPal study, and that the PsyPal study is also looking at these kinds of experiences and addressing a spiritual care component as well. So I think much of what I will bring to today's discussion will really be with attachment glasses, kind of, the stuff that we will talk about, and try to articulate some of that in attachment terms.
Thank you very much. Maybe to start with Débora, you have studied grief and pathological grief, and this morning you told us about your study. And can you tell us more about what you learned about the importance of grief in the palliative care phase, and what you think is relevant for this discussion also?
Yes, of course. I think that bereavement has been labeled as a poor cause in palliative care. No? And this is, so we have to take into account that for each people that is dying, this death directly affects to 5 to 9 other other people. So if we need to move from a patient-centered therapy to a more holistic way to understand human beings, you know, to a high-quality family-centered support. Because we have to be aware that if we don't do this quality family support, we can be multiplying the problems in the health of people in 6 months, you know, or in 10 months. So, to include bereavement in these programs is to do education and support in the pre-death area, to do a psychosocial and family support and spiritual support in the dying process, to transfer, do a good transfer to the patient, to the community support, that this is something that it has to be developed, and we have beautiful examples, as in Canada and Australia, in UK, in India, there is a revolution in community development around death and dying. And after that, to give bereavement support from those who need it after the death. So this will be ideal, but I know that we are at least a little bit far off that yet.
Yeah, Metten?
Can I ask a question about that? Because I was thinking about this involvement of the family in the community earlier also, because I can imagine that they're basically the ones that stay behind with the largest amount of grief after a person passes by. And if you think about this in treating people with end-of-life anxiety, with psychedelics, could this also be extended to the family? Could this experience, or having this experience, to suffer less from the approaching death, is that something that you consider to also apply to the families themselves, or maybe even in a group setting?
Absolutely. I think that from the healthcare institutions, family can be integrated as not co-therapists, but together in the sessions of palliative care, you know, as doing this meaningful experience together, you know. In the room, yes, why not?
And also having the experience themselves, you think?
But maybe you need to give psilocybin to someone with a diagnosis, and maybe the family doesn't have a diagnosis yet, no? So, but at least to be together, holding this space in the experience for the patient, this will be ideal. And the support of the community, this is something that we have in Spain that probably there are in other countries is not allowed, no? But in Spain there is a decriminalization of the plant medicines, you know? The only plants that are illegal is marijuana, cocaine, and cannabis. So community involvement, community can use plant medicines to support the bereavement family after that. But maybe this is an exception in the world. You know I'm very cautious.
Maybe a question to follow up on that, because it seems like you sort of touch upon the normal process of bereavement, and which can be very intensive, and where cultures have different forms for, and most probably the Western cultures have the least developed, or we did away with all of that, which has its complications. But maybe a question also for you, Houman, and maybe for both of you. How does a person look like who would need medical attention from this respect? Or where are we? Is it more of a societal community responsibility?
Do you want to answer?
Yeah, I mean, I think it is an individualistic decision. Like, I think these things require case-by-case assessment. The thing that I see a lot is lack of resources. And so palliative care in general seems to be underfunded. And so, we have a shortage of just offering basic services. So I think, the families definitely do take a hit when you don't have enough resources to cover the patients. But yeah, I think it's important to be inclusive of loved ones, and that's part of the definition of palliative care, is patients and families, and so I think this approach is important. Some individuals will have a lot more involvement, and some will be a lot more isolated, and so I think it should be tailored from my perspective.
Yeah, that's true.
And given that we have limited resources, where should we put our energy? Where should we put our focus?
I think that to have a family, a more holistic approach in the palliative care doesn't consume a lot of resources. It's just the approach that we take when we are working with the being as a whole, he, the patient, but the family is involved. So it's just, there is no evidence base about this kind of support, the evidence is very, very low. So we have to create it, but the first thing that we need is to have this approach that is not only the patient, it's all the system. Imagine we are treating people with several difficult illness, but there are palliative care in children also. How can you separate children from their parents in these moments? It's impossible. So it's just to change the perspective, to create this support program in a more holistic way.
And how would you approach, maybe all of you, what would be the next step to develop the evidence base, to make it payable? I mean, people have to do that, and they have to be employed somehow.
Well, you are designing 10 sessions, of psychotherapy, So maybe if this protocol is a little bit more open, and in these sessions are family involved, family persons involved, because maybe we can take care of them. Or maybe in this same protocol, just you can ask to the families, what do you need? What is lacking here, And maybe you can collect data in order to develop a new other protocol more broad to have a more holistic approach, for example.
Yeah, I can add something to that. I think and I'm speaking a little on the fly here, but first of all, I would like to say that Debora's work, I think, was the most inspiring thing that I saw at this conference. It's a beautiful, beautiful work, and not at all hard to justify, I think, from a healthcare perspective, because she's doing work showing really that they can prevent prolonged grief disorder from developing, and we know that bereavement is quite often associated with depression. With my perspectives, it really means same thing as heavy traumatization, because you're losing usually an attachment figure, or if you're losing a kid, it would be a person with whom you have a caregiving relationship, so that's also an equally strong affectional bond. Now, if the healthcare has the task of providing care to the whole population, I think in Sweden we have the idea of a universal welfare state as opposed to only one that's targeted to specific individuals. And with that frame of mind, I think it's quite motivated to say that, that this is warranted to finance. And health economics could probably come out on the side of saying that the prevention of depression and demoralization is actually worth it.
This is certainly a very central question that I've also been thinking about also in our discussion of setting up this research of what is actually needed to sort of have your outcomes of research contribute to this type of treatment being registered, which I think is really a very big challenge. And I think it's also connected to what you say, that the solidarity system that you have in Sweden, that we have in Europe in general, that in one way you ideally want to come up with a registration of a drug so that insurance companies and payers will actually make this available to everyone who needs it. But on the contrary, a lot of discussion has been going on about how complicated it actually is to move these type of treatments to registration. And even if you have a lot of evidence with 2 phase 2 trials, there's still a lot of very critical debate. I am not aware at this moment of any very large trials on psychedelic research, psilocybin, or whatever, any other compound in end-of-life anxiety. So I think that we're really quite far away from moving to a more generalized registration of any type of these treatments. And the challenge in actually designing those type of treatments is, as we've also discussed, how would you sort of describe or classify a thing that we sort of are moving away from more and more in psychiatry to actually have these patients fit into a system that's acceptable for payers? So normally you would want to say that someone suffers from depression, which is very heterogeneous, very hard to grasp either. And then you now have a sort of a new category which comprises of anxiety, depression, connected to being terminally ill, which is not really recognized, at least not in the Netherlands, I think, by the separate payment system that we have for mental health care. So there's a huge challenge in there. And it might force you paradoxically to sort of move towards a very narrow definition of these patients categories, sort of seeking for depressive symptoms so that you can at least explain to authorities that this is actually sort of a identifiable problem in order to have it in the end being paid for. But it's quite a complicated way to work around this. And the paradox, I think, is that there has been a lot of research actually going into psychedelic treatment for end-of-life anxiety. It's one of the oldest indications. There's a lot of research. We have some breakthrough trials that actually put this type of research on the agenda. And still, I think it's the indication that's most far away to having an actual chance of being registered. So in a way, I think that how we have solved that in Canada is super elegant. I don't think that it would be possible in the Netherlands because of these type of regulatory hurdles, and also from what I understood from the discussions that we've had so far with the EMA, that even though they're really open to having real-world evidence, that still phase 3 trials are required to actually register something. I think in the end we will find a way to get this done. But I would be really curious to learn from you, Houman, how you did this, and what we can take away from your learnings and actually moving forward in Europe.
Yeah, I mean, I think we were lucky. Like, what we were able to tap into was an existing system that prescribers could use to get access to any kind of medication that's not available. I think that's what's been unique, is that for example, new cancer treatment or new HIV treatment during the AIDS epidemic. So accessing that same pathway has been the argument. And when you have the medical system paying for medical aid in the system, this can't be worse than dying, right? It's like if you have the right to die, you have the right to try. I think it's a simple argument relatively based on human rights. So I think that's what comes to mind. And the other aspect is, I think, looking at places that do it well. I wonder if it's just the best way to start studying these populations that get access to such care. For example, in Montreal, we have a few hospice centers, and they're just doing amazing work. They all have bereavement, not just for the patients that go through the hospice, but anyone in the community. Because it's a cultural phenomenon that we need to change and address. And there's a taboo with psychedelic medicine, with palliative care. And this kind of thing just requires cultural shift and education, and perhaps studying what's already being done.
Can I just add to that? A third taboo is around spiritual and religious experiences, I think, in large parts of the Western world at present. And still they are quite common, and especially following bereavement, actually. So there's this classical psychology of religion literature showing an increased proclivity for strong religious experiences following the loss of a very important person. And there's something quite beautiful about that. The lost object, it doesn't leave your mind, and it opens your mind to interesting experiences that are also reparative. So that's just a third challenge to come to terms with culturally. I just attended a talk about secularization and the potential role of psychedelic chaplaincy that was quite interesting, where basically the presenters were in agreement that secularity is really not the opposite of religion, and that there is no fully neutral position here. And yet we are faced with the challenge of working with those sorts of experiences of a spiritual or religious kind, and we don't really know what to do about it because we're supposed to maintain worldview neutrality. So that's part of the matrix that also makes this difficult, right?
Yeah, so this is a topic which has a whole range of layers, right? Ranging from how do we get it into normal medical care so that it can be prescribed and registered. And for that we need, for example, an MDD criterion, even though we know that MDD is it's also very heterogeneous, and the processes behind it are much more relevant than just calling it MDD. And what you're doing and what the committee in the Netherlands who gave the advice on MDMA yesterday did is we should allow for some form of compassionate use, but then in a way where we still collect data and learn from it. You could say that we don't want to go there. So we'll just do another societal model. We don't want to work with industry, we don't want to work with EMA, etc. And I think what happened at the FDA shows how difficult it is to get into this system for a whole bunch of reasons. Can you solve this?
Not me.
Well, maybe with a little help from late Wittgenstein, if we started kind of just realizing that all of these boundary conditions are pretty fuzzy, and we actually took that idea seriously, I think we would be on the verge philosophically of actually becoming a little more flexible in decision making, but it requires a rethinking across the board, of course.
Yeah, but in the Disciple project we have these discussions, right? So we chose to do the obvious thing, which is to require an MDD criterion for patients to start, because in the system that is a necessary requirement. At the same time, we measure demoralization, death, anxiety, end-of-life distress, and we do qualitative interviews to see what kind of psychological processes are relevant and how people evaluate. And then we hope that later on in the trajectory, we learn so much from it that it might help us better select patients.
Something that we can do from Spain is, because it's not a requirement for us to have a clinical diagnosis to use psychedelics. In my case, I was working with ayahuasca, and in the prevention of a prolonged grief disorder, people was not diagnosed. So maybe we can assess another kind of transdiagnosis, use transdiagnostic scales or another kind of variables in order to bring evidence, and if someone needs to use it in a compassionate use, at least to be supported by any kind of evidence that is not just MDD. You know?
And would it then be needed to do it by qualified therapists, medical doctors, all of that, or would you think it could also be outside?
I think that we can think about that in different ways. We can do it as a clinical research study, but not as a clinical study, or we can do an observational study outside using this protocol inside of the community support of the people who is dying and the families. So the thing is, how can we do in our countries, with our own regulation, to advance this field in a more wider way, than the specific things that we need to achieve for the EMA.
Houman, what would you say about that? Would you scale it to outside?
I mean, it's a good question. I think there's no easy answer. I think looking at indigenous practices that have existed for hundreds of thousands of years, looking at the dedication and training it's taken for someone to assume the shamanic role and to have the community involved in a lifelong process, I think that sort of tight cultural framework is necessary. So, yeah, we either have to have that culture in place, otherwise in a systematic way try and create that and perhaps study it as it evolves. For example, in Oregon, what they did is they said, you don't have to be a healthcare professional. You can have a high school diploma and come do this many hours of training and be a facilitator. And that, by definition, is not medical treatment. I think when people are more officially mentally ill and challenged, they need healthcare professionals involved, especially if their medication's on board, usually a psychiatrist on board. So I think multidisciplinary is actually one of the ways to do this. And community involvement, it doesn't have to be all healthcare professionals or no healthcare professionals. We need to work together. And I think the Roots to Thrive model that they have in British Columbia, credit to that team, that's what they do. It's like a multidisciplinary community, elders, indigenous, everyone's involved. And I think that's how it should be.
Yeah, very good. Thank you so much.
Okay, if I can add to that, I'm thinking about it. In the end, I think there will potentially be a huge difference between the person suffering from end-of-life anxiety and someone suffering from treatment-resistant depression. And in these trials that we're doing, many actions are put in place to mitigate all the risks connected to someone having treatment-resistant depression, for example, reacting with suicidality after a challenging experience. I can also imagine that in this population, those risks are a bit lower. So you can maybe be a bit more relaxed about the level of control that is required to actually follow up on people afterwards. But that may be an assumption. But I can imagine that if that is the case, that it will also put less stress or a bit less stress on the amount of personnel that is required to actually do the treatment, and also the requirements you'll have to get this type of treatment registered. But I don't know what your experience is in that, because I can also imagine that it will depend on, for example, the psychiatric history of the person suffering at his end of life from end-of-life anxiety, the type of risk that you would expect.
Yeah, I agree. I think if someone is already at baseline suffering from a mental health disorder, they're going to need more care, and so that care usually is better delivered through a professional network. But again, I think cooperation and including families, including the community, that's the way to sort of spread the responsibilities. But yeah.
In fact, in Canada, they have a beautiful program of community development around death and dying. In Canada, also in UK, they are growing these compassionate communities. In Australia, also in India, and in many places. So we can take these examples of community development around death and dying and to put it in place as a priority, because we need to understand human being not as an isolated individual, but as a part of a web, and all are involved on that.
Yeah, it's really interesting. If you can do it like this, you are much more flexible in determining who is going to do this. Exactly. Yeah. Even though, but that's very much reasoned from outside psychiatry, we very much think about and value the idea of we have to have certified trainings, everything needs to be certified and controlled, just to make sure that these vulnerable patients are not being put in a more vulnerable position if an unqualified person does something, or they get in trouble differently. So I would still think that some sort of quality requirements would apply also to these community facilitators, but maybe you can be more flexible.
And maybe a question to add to that. So it's palliative care, so these patients will have medical treatment. They will have a physician, they will have a nurse, they will be seeing a medical team, and they will be their primary point of reference with healthcare during this process. How are we going to collaborate with them? Should we involve them more actively into this process? What are your ideas about that?
Well, usually in the healthcare institutions there are like a health connector. So people bring their necessities, their needs, their wishes also, and the healthcare connection in the healthcare institutions transfer these needs to the community supports and resources that are around, you know. So they work in collaboration, but this is not a health, medical or physical doctor that has to need that. It's more a health, general health community person that is in the institution, you know. I don't know if I explain well.
But they need to sort of be accepting of what guys like us are going to do, right? And they need to be able to relate to that and to see the value of it, and also to be open to what patients tell them. Do you have experience with?
Yeah, I think it's important that everyone's on board. You know, if you have, you know, the care already is siloed, and if you have opposing forces, especially with these, you know, opening medications, it's just, there is risk of harm there. And so the way we've done it is definitely making sure everyone's on board. And sometimes, for example, the oncology team is not on board and we won't move forward. Or if another healthcare provider or even family member is not on board with the treatment, we don't go ahead because it could just risk further harm down the road, either for the patient or systematically. And I mean, I do want to say that in Canada, we've managed to get this special access, but it's still very challenging. And they still give us a hard time because everything we do has to be evidence-based, and the evidence is limited, and I think so the study you're starting is very important. But I still have to have a lot of arguments with Health Canada. If an individual is suffering from cancer-related distress, if they're not dying, they wouldn't want to give them access through that pathway. So it's a bit of a weird situation because you're supposed to be in a medical emergency, meaning your body needs to be shutting down to qualify for this pathway. But sometimes people are in this state for a number of years suffering and not actually dying. And you know, at the end of life, you're probably too ill to receive the treatment anyway. So there are a lot of complexities.
Yeah. And before you answer, if people have questions, please go to the microphone.
Yeah,
and then,
just something very brief, which is partly outside of this specific theme, but I also think that the criteria for evidence-based need to be loosened a little bit, because it's actually funny that across large parts of the world, it's a nomothetic definition of evidence that is based on general principles observed on other people, and then that's used as a foundation to prescribe something at the individual level. So a different way of, more flexible way of looking at evidence would be to implement something at the individual level, evaluate that in a kind of experimental design, and so that would create much more flexibility, I think.
The FDA has some way to cover.
Well, I think in part they really do need to study logic, because you cannot derive conclusions from the general level to the individual level.
Yeah. Thank you. Is there a question? Yes, please.
So I'm wondering, because it seems like there's a difference between geographical locations and how we set up the accessibility to these kinds of substances. And I'm hearing Maarten Somers talk about how do we define kind of like the inclusion criteria for people being able to access these kind of substances. And I was wondering if we could learn something from the way we organize euthanasia in terms of hopelessness as an unbearable suffering as a form of inclusion. What are your thoughts on that?
I think you talked about that this morning already a little bit.
Yeah, for sure. I mean, I think the idea, I mean, I said it earlier, but if you have a right to get killed in the system and the government pays for it, then, you know, when you've reached that point, it's just a matter of giving people the option as a human right, because essentially this medical aid in dying is a human right issue, and so is having this experience. It doesn't have to be pushed onto people, but if they've reached that point of desperation where they're willing to end their life, you know, why not give them this option and to study it in a systematic way? I mean, that's like the way to do it, you know.
I think it's actually an interesting idea because you move away from this whole psychiatric diagnosis thing, but it would require some flexibility also of the regulatory authorities to be willing to view it like this, that the actual amount of suffering would be the inclusionary criterion. Or,
well, yeah, for euthanasia you need a diagnosis also. So you have to have a medical or psychiatric condition that has been treated and unsuccessfully with everything we can think of. And that's also sort of the base qualification for compassionate use, right? So we think that's not such a bad idea. Thank you. Any other questions or comments? That side, sorry.
Hi there. I'm just wanting to give a shout out for ketamine as not just a placeholder medicine, but I think when we're worrying about sufficient justification for using unauthorized medicines yet, or not fully legal yet medicines yet, the ketamine is not just a placeholder, it's actually being off-label, there's a bit more scope to be able to use it for more broader categories of suffering, for palliative, not end of life, but for
Do you have experience with it?
I'm just starting.
Yeah.
In South Africa.
Yeah.
We've got a large private network called Chariot Health that do in-home care, who are quite open to looking at ketamine and introducing it as part of, and I'm a ketamine therapist. Yeah.
And that would be for end-of-life distress-like phenomena?
Well, I mean, because they use ketamine already for pain relief and for other chronic conditions, you would add that in as an antidepressant, as well as for end-of-life anxiety. You know, it can be used earlier on in this illness process to improve quality of life very effectively and help with end-of-life, especially when people are quite incapacitated and not really maybe ready for a 6-8 hour journey that the other beautiful medicines would provide.
Thank you very much. Any reactions to that?
I think this is actually a really interesting idea. I did give this some thought, but for example, there is already a challenge in the Netherlands where esketamine nasal spray is only offered to patients who suffer from depression, who have at least tried to antidepressant plus augmentation. So, for example, if you would now want to try that for a different indication, you would sort of need to negotiate with the insurance company to see if they actually are willing to give that. So, esketamine nasal spray.
Well, you can call Groningen.
Yeah, I just want to say, but maybe you have other ideas about it.
We do oral generic esketamine, so that's how we started with it.
So if you can apply that somehow more broadly, that would be really interesting.
We're doing a pilot in oncology with esketamine. We are on the dot, so I'm sorry we cannot take any more questions. I would like to panel, because the title of the session is Advancing Psychedelic Treatments at the End of Life. So what would be your final thing we should do to advance this field? And maybe, Pier, can I start with you?
Well, I don't know it that well, so I should probably be silent.
Thank you.
I think we should challenge ourselves to be a bit more creative with the definition of the type of patient than we do in psychiatry, because maybe that could be helpful. Yeah.
Thank you. Débora?
For me, is to take a more holistic approach in this intervention that we are giving.
Thank you very much.
Yeah, I mean, I think the ketamine idea as one example is a great idea. We're just passing one in our hospital for palliative care, and I think more research should be done with this available medication that can be used off-label.
Thank you very much. And if I got the question, I would say we are going to work very hard on this project and hope we get some answers. Thank you very much.
Thanks.